Hello and welcome everybody. We're just letting the last few people in out of the waiting room, so just a few more seconds and we'll be underway. We are absolutely delighted that you were able to make time in your busy schedules to join with us today. And we've just got a few more people popping in now as we go. I would like to introduce myself. My name is Robin Smart. I'm a public education coordinator with the Alzheimer's Society Waterloo Wellington, and I'm very, very pleased to be the host today. So I'm going to start with a little bit of housekeeping, and after that, we will get right into the session today. There has been a huge amount of interest. We had 167 people sign up to attend today. So I think that that shows a need for this information and a level of excitement about this talk today. So again, thank you for making the time to be with us. I want to acknowledge that we are located on the Haldimand Tract, traditional and unceded territory of the Anishinaabe, the Haudenosaunee, and the Neutral Peoples. This land is part of the Dish with One Spoon Treaty between the Haudenosaunee and the Anishinaabe peoples, and symbolizes the agreement to share, protect our resources, and not engage in conflict. It encompasses 10 kilometers on each side of the Grand River, and 90% of the land has never been paid for. I encourage you to research the history of the land you live and work on and the treaties that are tied to that land, as we are all treaty people, and it is our responsibility to honor all relations. If you are not from this area and know the territory where you are located, please share it in the chat now. Currently, everyone will be able to see your replies, but in a few minutes, we will be switching the chat feature, so any questions or comments put into chat will only go to the host and panelists. The chat will be our method of communication today. You may have noticed that your cameras and microphones were off when you entered the call. This is to eliminate background noise and to protect your privacy, as this session will be taped for the Alzheimer's Society YouTube channel. If you wish to submit a question for the panel, please use the chat function. We will do our best to address as many questions as possible during the time available. I hope you enjoyed the mini slideshow in the Zoom waiting room, introducing you to our panelists. But if you didn't get a chance to watch it, a copy of the panelist bios and 2 handouts, as well as the slides, will be sent with the evaluation later today. Now, I'd like to turn the call over to Dr. Nicole Didyk, our first presenter.
Thanks very much, Robin. I'm Dr. Didyk. I'm a geriatrician working currently in Cambridge, and I've been in the Waterloo region for about 15 years. Of course, you probably read that in my bio. So I'm going to go ahead and share my screen, and I have a few slides to present to you. I'm going to present for about 20 minutes today, and we're going to talk about cannabis and dementia. So we're so lucky to have such a great panel today, and there will definitely be some other perspectives on cannabis and older adults, but let's start with just looking at cannabis and its role in dementia. So everybody can see my slides. That's great. We'll just do a little overview of dementia, and I know that most of you probably have some idea of what dementia is, but let's start with just reviewing that, and then talk about why we would use cannabis to treat some of the symptoms of dementia. And let's look at the evidence about whether or not it can help. So let's remember that dementia is not a normal part of aging. It's on the spectrum of cognitive change as people get older, but it's definitely not typical, and it doesn't happen to everybody. There's some normal age-related memory change that is almost universal, but then there is, on this spectrum, there's also what's called subjective cognitive decline, where people feel like their memory is worse than it should be for their age, but there's no objective evidence for that. They would test within a range that would be considered normal. Beyond that is mild cognitive impairment, where people do have some objective or measurable difficulty with memory that's more than normal aging, but they don't actually have any functional decline. So it doesn't affect their day-to-day life. And then there's dementia, which, as I said, is definitely not normal. And it's usually caused by some neurodegenerative process like Alzheimer's. So dementia is kind of the umbrella term, and Alzheimer's is the most common cause of dementia. And so sometimes people ask, what's the difference between dementia and Alzheimer's? Oops, don't know where those squiggles are coming from, but for sure, dementia and Alzheimer's are often used interchangeably, and I might use them interchangeably in this talk as well. So let's go to the next slide. This is the definition of dementia that's in the DSM-5, which is kind of a manual that we use for neuropsychiatric disorders. And it's also called, dementia is also referred to as major neurocognitive disorder right now, to kind of distinguish it from that mild cognitive impairment. And it does affect memory and learning, right? Which we usually think of, and when we think of dementia, we think of memory, but it can affect other cognitive domains as well, like attention and language skills. It can affect perception, motor perceptual skills. So people might have trouble figuring out how to move their bodies, how to situate their bodies to get in and out of a vehicle or do something complex like that. It can affect executive function like decision-making and planning, and even social cognition. So knowing what to do that's socially acceptable when. Dementia has to be acquired, so it can't be something that a person is born with. And it has to get in the way of day-to-day function. That's a critical piece, and that's a big part of my job when I'm working with a patient and family regarding a diagnosis of dementia. You know, I have to find out, okay, how is their day-to-day function? How has it changed? And is that change due to their cognitive function? And of course, we have to rule out delirium as well. So these are the parts of the brain that are affected in Alzheimer's. And, you know, the different parts of the brain that are affected cause different symptoms. So in the entorhinal cortex and hippocampus, that's what we think of most often as affecting memory. And short-term memory is what changes first, right? So oftentimes people are surprised that a person is living with dementia because they remember things from so long ago, but it's the short-term memory that changes first. And then other skills are in the actual cortex of the brain, the sort of outer part of the brain. And that is where, when that's affected, there are changes to language, reasoning, and social behavior. So the cognitive changes of dementia are often what we think of and what we sort of test for in the office. We ask about activities of daily living because those are affected in dementia as well. But there's also behavior change. And that is quite common in people living with dementia. About 75% of those living with dementia will have some change in their behavior, which we call responsive behaviors, because it is always in response to some unmet need, but how it shows up can be very different and very, you know, it can be inappropriate to people who don't understand the need. So we call them responsive behaviors. Responsive behaviors are more likely to happen in people with moderate to severe dementia. And the responsive behaviors can be all of these things that are listed here. And they can happen to different degrees and be, you know, have different frequencies and triggers and so on. And agitation is a word that comes up a lot when we talk about responsive behaviors. And looking at this list of behaviors, a lot of them are sort of preceded by agitation, or the agitation is a part of it. And, you know, a lot of times in geriatrics, this word agitation was used, and it wasn't really defined until 2015, actually, when the International Psychogeriatric Association said, okay, well, what is agitation in dementia? And so it is a behavior. It involves excessive motor activity. So the person is not usually flat or drowsy. They are moving more, there's more energy, and there can be verbal or physical aggression. It is distressing to the person, so they're not doing it like for fun or as a leisure activity, and it causes disability. So it gets in the way of the person's ability to receive care, to do activities that they enjoy. Sometimes it can even affect a person's living situation. So that's what we're talking about when we're talking about agitation. And the way that we treat agitation is we have non-pharmacologic and pharmacologic interventions. So, and that's a classic sort of approach in geriatric medicine. The non-pharmacologic interventions, some of them are listed here, and they can include things like coaching for the care partner to try to identify those triggers and either avoid them or respond to the response differently. Therapeutic robots can help. So there's a little seal, the Paro seal, and there are cats that are sort of robotic and can provide some stimulation and some support, and sometimes they're helpful. And then other things, hand massage, snoozle in rooms, if people know what those are, where it's kind of a room that's often in a long-term care home. And there's a lot of different sensory things in there that can be distracting and can kind of reset a person's mindset. But these treatments aren't always as efficacious as we would hope they would be. They can be expensive. And like, I think the Paro seal is about $800. And I think that, and they can be difficult to implement. So they're not perfect, but we always try to look at some of those non-pharmacologic interventions. A big part of my job is prescribing medications for responsive behaviors. And we can use the dementia medications or cognitive enhancers like cholinesterase inhibitors like donepezil, or ribostigmine or galantamine, or memantine, which acts on the NMDA receptor. And they can help with some of the symptoms of responsive behaviors, but they don't usually help too much with agitation. The antipsychotics are probably the mainstay of medications that we use, but most of you probably know that there's a downside to the antipsychotics, or there can be some risks, and I'll mention that a little bit later. There's actually, if you were to Google the name of some of the antipsychotics or atypical neuroleptics, so that those are things like quetiapine, olanzapine, aripiprazole, and risperidone, you'll see sort of this FDA Health Canada warning about the potential risks. So there is that downside. And then antidepressants as well have some benefit. Cipralex, for example, or escitalopram has been looked at, but they are not tremendously effective, and they do have some cardiac risks. So if we look at the antipsychotics, and I hope this slide is big enough, we can see that they are somewhat effective. So quetiapine doesn't seem to be very effective. That's sort of that third one down. And the more triangles and lines there are on the right, it means they were more helpful than the placebo was. So we need to treat about 5 to 14 people. That's NNT, it stands for number of individuals needed to treat, to help one person. But for every 100 people that we treat, there will be one death. So we do know, and I do disclose when I start these medications, that it can increase the risk of stroke or death for someone with dementia to be on these medications. So we only use them if we think the benefit will outweigh the risk. We use the smallest dose possible for the shortest time period possible. So we do still use them. They are somewhat effective, but if we have an alternative, that would be great. So enter cannabis. And, cannabis is very trendy. So why not look at that for just about everything? And I know probably a lot of health providers have found that people have come into the office and, kind of wanted to try cannabis for a lot of different disorders. So cannabis is a plant. It's also called marijuana. And there's two different species. There's sativa and there's indica. Sativa generally has a higher THC ratio than CBD. So what I mean by that is there are kind of two main compounds, active compounds in the cannabis plant. So there's the THC, which is tetrahydrocannabinol, and then the cannabidiol or CBD. And they both act on the brain, but the THC is more likely to produce sort of psychiatric or psychotic symptoms rather than the CBD. So when I say the CBD is non-psychoactive, it does act on the brain, but it doesn't tend to have the same kind of activity profile as THC. And we have cannabis receptors in our body. So we even produce our own endocannabinoids, they're called. And we have receptors that cannabis acts on. The CB1 receptor is mostly for THC, and then there's the CB2 receptor. And when those receptors are activated, it can have different effects, and I'll show you that with a little picture of the brain in a moment. But generally, the things that we see are an increase in, well, it could be an increase or decrease in anxiety, an increase in appetite, a decreased effect on pain, and some sedation. And you can see here, I've tried to sort of bring back that little brain diagram and show where the cannabinoids would act, where the endocannabinoids would definitely act, and where exogenous, or if we give cannabis, where it could act as well. So in the cortex, this is where we often see some of those negative things that we might not want to see in an older adult, like the perceptual distortions or that high. They can cause psychosis and affect memory. Same thing in the hippocampus. It can affect balance and coordination at the level of the cerebellum, but it can stimulate appetite in the hypothalamus. It can help to regulate anxiety and hostility in the amygdala. So these are all kind of deeper brain structures. And at the level of the brain stem, kind of the base of the brain, we can see improvement in pain and nausea and a little bit of drowsiness. So some of these effects are kind of, we might think of as undesirable, but some of them sound like they would help in agitation. And on top of that, we know that cannabis has other properties too. So it's an antioxidant. It can enhance our own endocannabinoid systems. It's anti-inflammatory. And so it might help with some of the, pathological processes that happen in Alzheimer's. It might help to reduce some of that. That's mostly theoretical, but that certainly is a positive compared to some of the other medications that we use. It also can interact with THC. So say you're just smoking cannabis or eating some plant, eating a gummy, if you take CBD and THC at the same time, the CBD kind of interacts with THC to mitigate some of those undesirable side effects. So how can you take cannabis? Well, you can smoke it, you can eat it. There's an oil, and then there are synthetic forms as well. Dronabinol is available in the US and not Canada. Nabilone is available here. Dronabinol is like a synthetic THC, and nabilone is it's derived from THC. And there are a few other types as well, but those are kind of the most common ones. And it's kind of exciting that we actually we have had a trial here with some Canadian researchers at Sunnybrook, looking at nabilone for agitation in Alzheimer's disease. As doctors and geriatricians, we always want to do something that has some scientific basis. So this is really cool that there's this pretty recent study. So I'll just talk about that a little bit. It was pretty small, but it was well designed. They had 38 people that were living with Alzheimer's or a mixed dementia of Alzheimer's and vascular dementia etiology. And these folks had moderate to severe agitation. And now nabilone is approved as a treatment for nausea. So this is the kind of dose, this 1 to 2 milligrams a day is what people would take for nausea, but it's not really, approved for use in dementia. So this would be an off-label use. And they did actually find that there were some improvement in levels of agitation and fewer overall behaviors, but also very importantly, it helped with the distress of the care partners. And this was a blinded study, so people didn't really know if they were on placebo or nabilone. but it seemed to help. It didn't seem to help with pain, for example, and it didn't really help with weight, like weight gain, or it didn't necessarily seem to cause weight gain if that was a desired outcome. And sedation was the main side effect. So if we look at overall, if we look at all the studies of cannabinoids for agitation, and there haven't been loads of them, but again, this is kind of this diagram where there have been multiple scientific studies that have been done, and then a meta-analysis, of course, is kind of a way of systematically looking and seeing, compiling all this evidence as best we can and looking to see what the overall result is. So on this one, it's opposite to last time, that if there's a diamond or a line on the left, that means that the cannabinoids were helpful. And we can see here that overall, it did look like it kind of favored having the cannabinoids versus having a placebo. So THC is right on the line there, but for the synthetic cannabinoid like nabilone, for example, and this does include the trial that was done that I just showed you, it does seem to show some improvement. And interestingly, the more cognitive impairment that the person had, the more likely they were to have some effect from the cannabinoids. So that's very encouraging. The Canadian Agency for Drugs and Technology in Health also did a systematic review. And I think they looked at about 57 papers, but they only sort of found 2. One was another sort of systematic review, and one was a trial. And so, a total of 12 studies were looked at, 178 patients, and they did look at pure THC, dronabinol, nabilone, and then some marijuana that was put in a cake and given to people. And they looked at outcomes, and this is NPI is the neuropsychiatric inventory, and CMAI is the Cohen-Mansfield, I don't know what A is, maybe agitation inventory. And those are tools, there's kind of like checklists that we use to look at responsive behaviors in dementia. And they did find that overall, when looking at all these studies, there was a decrease in agitation and disinhibition, which is kind of where people lose their inhibitions and they might be impulsive, for example, aberrant motor behavior, and not being cooperative with the care. So that's encouraging too. So this was kind of a quick tour, and I'm very happy to answer questions, and I'm sure we'll learn more as the rest of our participants give their presentations as well. But what I wanted to share with you is that there are definitely gaps in our ability to help people who are living with dementia and their care partners. And one of those big gaps is around responsive behaviors. And so cannabis might have a role in that kind of treatment. It does have neuroprotective and anti-inflammatory properties, which could theoretically help with the processes of Alzheimer's, for example. And, cannabis and CBD can help with lowering anxiety and causing a little bit of sedation. I think we're getting more evidence now that things like nabilone, which is a pill, and which it would be pretty easy to deliver, can be helpful in the agitation of dementia. But we don't really have good evidence for other modalities like smoking the cannabis, eating it, or the oil. So I know that a lot of people are using these forms of cannabis, but unfortunately, right now it's not really clear that has a high level of scientific evidence that we can kind of recommend it broadly. So that's I'll leave you with that as well. So that's all I wanted to present. I do see a question in the chat, and I'm not sure if I should answer that question now or wait till later. But definitely, definitely with the, well, I'll just answer it then. With the legalization of cannabis, are more people asking for it, and do I prescribe it? So yes, very much people are asking about cannabis. And I think people, are feeling hopeful that it might be helpful with them. I don't prescribe it personally, but I do refer people to cannabis clinics where there are physicians who've had a little bit more training in the prescribing of cannabis, and most of those people are receiving oils. But, after reviewing this evidence, I might consider starting to use the synthetic cannabinoid, Nabilone, which I could, prescribe as I do other medications, and see how that goes. And I do see another question, but I think I've passed my time. Is cannabis, I'll just quickly answer it and then maybe no more questions. Would cannabis be considered a restraint? I don't think so. I don't have a clear, when I think in my mind of what is a chemical restraint, I guess I do think of the neuroleptics, and I think of maybe also benzodiazepines. I don't know that what I know about cannabis, I wouldn't consider it a chemical restraint right now, but others might disagree. And I don't know if Nabilone is covered under ODB. I don't know. I haven't prescribed it enough to know. I mean, it might be, the interesting thing is it's only approved for things like nausea. So if we're using it off label, that might be a challenge. So if anybody else knows, please chime in. So thank you so much for your attention and your questions, and hopefully we'll have time to answer them later or entertain some more questions. I'm very pleased now to hand over to Patricia Ferrari from the Alzheimer Society of Waterloo Wellington, and hear what she has to say about cannabis use with older adults.
Thank you, Dr. Didyk. Hi, everyone. I'm Patricia. I'm a First Link coordinator here at the Alzheimer Society of Waterloo Wellington. I'm also a previous medicinal cannabis counselor and educator. So what I would like to point out today is that there's more to cannabis than most people know. In addition to the CBD and the THC having beneficial properties, there are also different terpenes in cannabis that can help with different symptoms. So I would encourage everybody to do a little bit of research about that. And I do have some information about the coverage for cannabis by OHIP. So the prescription Nabilone is covered by, it has a drug identification number, therefore it can be used under a benefits. Whereas a CBD oil that has been prescribed does not have a drug identification number. So unfortunately, it's not covered by OHIP or by most benefits unless you have a private benefits plan. The other thing that I wanted to talk about was, if you are interested in taking cannabis, I would advise you to go to a cannabis clinic. Just like Dr. Didyk said, there are physicians that have further training on different cannabis properties, as well as which manufacturers would be best for you. So I would highly advise that you reach out to one of your local cannabis clinics that does have a physician to prescribe to you. That's pretty much all I have to say about that. So I am going to pass it over to our other ASWW team member here, Jeanetta.
Hi there. Great. Thanks, Patricia. So as she mentioned, my name's Jeanetta. I'm a social worker here with the Alzheimer Society Waterloo Wellington. I just wanted to share some information about our programs and services for some of you who may not be familiar with what we offer at the Alzheimer Society. So I'm just going to share my screen here. I've got a little graphic to share with everyone. Just highlighting some of our programs and services. So we do have services in French. We offer individual support to people in the Waterloo Wellington area in French. So if you are interested, you can contact the Society. We also offer exercise and social recreational opportunities We offer weekly and monthly social recreation and exercise groups like Minds in Motion for people living with dementia. So you can join us in dementia-friendly conversation and activities through these programs. Our education seminars discuss a variety of dementia-based topics, and we offer repeating general courses as well as rotating special topics like this one to best educate our community. Our registered social workers provide safe, confidential counseling, focusing on how dementia impacts your mental health and well-being. And we also offer groups to connect you with other care partners or people living with dementia for support. Our enhancing care programs are multi-week skills-based care partner programs focused on common caregiving themes and practical skills needed to care for people living with dementia. And our First Link Care Navigators can assess your needs and create support plans that are right for you and connect you and coordinate with services and follow up to make sure that things are working and support you along the way. We do welcome self-referrals as well as referrals from community agencies. So I'm going to stop sharing there, and I am going to pass it off to Julie Kerkhof, who's going to share some more information about aging and cannabis use with dementia.
Okay, I'm going to assume that we're good to go.
You're good there, Julie. You're good.
Thank you very much. I had been, I escaped during Nicole's, it somehow crashed on my screen. So I wasn't sure if I was able to sneak back in or not. So, okay. So thank you very much. Robin, thank you so much for the invitation here today. And thank you, Jeanetta, and everyone else who's spoken already. So I'm here to actually represent an older adult and substance use working group. I belong to this working group that is has a variety of both clinicians and people who represent various companies and programs throughout Waterloo, Wellington, in addition to those with lived experience who sit at this table, and we connect each month to look at some strategies and ways to offer education, look at ways to reduce stigma in our region. And over the last couple of years specifically, we've worked on creating 2 infographics, and this is one of the 2. So this infographic that will be shared with everyone at the end of today's session is just a 1-pager. It kind of reduces and streamlines and hopefully keeps it simplified on what an older adult needs to know or could want to know in regards to cannabis, especially in the flavor of older adults. And I want to maybe highlight that this is not a dementia specific infographic, but it is an older adult specific infographic. And I'll just spend a moment or two kind of going through what you can expect to see on this 1-pager. And it's really brought into 4 sections. And if I can scroll down, oh, will it let me do that? Yes, it will. Good. So the first on the top left-hand corner, it just really talks about the THC and the CBD, which Nicole or Dr. Didyk had already shared the differences about. So it kind of streamlines and gives that in 1-sentence form for each. The second part kind of looks at, is cannabis helpful or hurtful? And I think that the takeaway here is really that it affects everyone differently. And I wonder if the terpenes that Patricia spoke to really actually is the key feature here as well. But recognizing that how you consume, how much you consume, what it is you're consuming, and those individual or unique factors of your own body, your own person, how you became who you are in that moment, will actually all play a role on how the cannabis will impact you. And so we've just listed here throughout this infographic, just different ways it can impact you. So that's the second part of this infographic. And I'm going to scroll back to the top and look on the right-hand side of this infographic. And then, oh, sorry, there we go. And then the third part rather is around how to look at cannabis use in a safer way. And it's just some points to consider as you make that decision to incorporating this in your life or not, and how to go about doing it in a safer way. And then the final section on this infographic is actually resources. So where you can seek out additional information if you are curious or interested. If you want to find places to actually purchase the cannabis, where to go to look for that. And then if you are struggling with the substance use, if it's cannabis or another substance, and you want to look for support locally, there is some numbers and some connections for you as well. I will also add that our working group is in the process of completing a pilot project and sending out, oh, sorry, I'm trying to get rid of this on my screen here, sorry. And we're working with local pharmacies throughout Waterloo, Wellington to actually disperse this infographic throughout the community and their care partners. So I'm going to end my talk there at this point, and I know that Robin wants to leave a fair bit of time at the conclusion here to review questions that the crowd may have. And I think that is all of our speakers. It was 4 of us. So I'm going to hand it back to you, Robin. Thank you.
Thank you so much, Julie. And that's pretty exciting to hear that you could work alongside pharmacies and get this information dispersed in a more wide venue. So that's pretty exciting stuff. And I appreciate everything that all of our speakers had to say. I would just like to let people know that although the Alzheimer's Society is not an emergency service, we do offer some opportunities for people outside of regular business hours, and our social and recreational programs are offered on Saturdays as well, so that if there is a working adult child that wanted to participate, for example, in Minds in Motion with one of their parents, there is a Saturday class available, and there are some other activities available on the weekend. So what I'm going to do is just go down to the chat. There has been a question put in so far, and if you do have other questions, now is a good time to type them into the chat. I'm suspicious that this might be directed to Dr. Didyk, so I'm going to ask Nicole. In fact, I'm going to ask all of the panelists, if you could turn your cameras back on, I would really appreciate that from, and Pete, I'm sure you're going to, yeah, spotlight everybody, perfect. And so Nicole, I think this is for you. Dr. Didyk, my mom has started with facial scratching. Would this be considered some sort of anxiety?
Thank you for the question. Yeah, I mean, we do see people who get into scratching or picking behaviors as part of anxiety, absolutely. And unfortunately, sometimes it can self-perpetuate, because once a person starts picking, then there's more to pick and there's more itching, and it's just like, it almost becomes like I think I call it neurodermatitis. I hope that's the right term for it. So that's a challenge. So yes, anxiety could be at the root of that. I mean, I think like everything, we talk about non-pharmacologic things first, right? So before we go, treating anxiety, we'd probably want to make sure there's nothing irritating. There's nothing else that, the person could have a reason to touch their face or scratch it. And then, yeah, so if it's anxiety based and it's like part of an agitation syndrome and the person's living with dementia, then cannabis might have a role there in kind of calming that anxiety, along with those other non-medication based things that you could do to try to reduce that.
Would you just start with something like a nice topical lotion that might be soothing in the moment at the time? Do you think that?
I would probably start that. I'm a bit of a skincare junkie too. So whenever I have a feeling on skin, I go for a product. But a pharmacist could probably tell you like what is the most likely to be non-irritating and soothing. And that would be a great way to start. And it might also give some tactile, the act of putting it on a couple times a day might give, some tactile stimulation. We're always looking for that unmet need, right? In any kind of responsive behavior. So yes, if there's that unmet need there, then a topical cream would be a good way to go. I don't know if I'd use a cannabis-based cream. I don't know what the evidence is for that, but.
I was actually thinking of more a hand lotion type cream to start with.
Yeah, something mild, not fragranced.
Yeah, unscented
would
for
be
sure.
great. Yeah, pharmacy would be your friend there.
Sure. So two more questions here, just to confirm. People would like clarification about cannabis and pain. If you would be kind enough to speak to that. I suspect that that's another Nicole question. I could be wrong. Julie, do you have anything you want to throw in there? Being an RN, you might have something to add. But Nicole, cannabis and pain,
Sure.
if you could just clarify.
Thank you. And anyone else, please chime in. And certainly I've seen a lot of people trying cannabis for pain. And, we know that it does act, as we showed, it can act on the brainstem there and it can modulate pain. So theoretically, I think there is some good reasoning there. There have been some trials in neuropathic that, nerve mediated pain. So that's a lot of the kind of pain people get if their nerves are changing related to diabetes or something else. Often it's in their extremities, like their legs and feet. So, and you know what, I didn't do a deep review of the efficacy or, how helpful it is in there. But yes, for sure, I think that when we've tried other treatments for pain, I think it's reasonable to bring some cannabis treatment on board. And again, I think it's really helpful, as Patricia said, to work with a clinic so that they are, you've got some medical supervision, you've got somebody who knows the other meds you're on and how they could interact, because that could be, because it's not totally benign, right? It's a plant, but it can have side effects that you want to know about.
Everything has side effects, no matter what. Everything we put in our system has some effect on our system. Yeah. Nicole, I'm just wondering, before we leave the topic of pain and go to the next question, I was thinking seniors in general, arthritis is certainly an issue, a painful issue for so many seniors, and it affects their day-to-day lives in and out. Would cannabis be something that you would consider if arthritis is the pain issue?
Well, and again, like I have to say, I didn't do a super deep dive in there. So I would love to be able to, look more scientifically and get back to you. But I think that, pain is complex, and osteoarthritis pain is often mechanical. But if people are living with it long enough, it can end up, having a neuropathic pathway too. So yeah, I think I think again, working with your medical team, there could definitely be a role for cannabis there.
Okay, great. Thank you. Yes, Julie.
Julie, what do you think?
I'll just add to that too. And I agree that doing the deep dive and having the evidence to support the feedback on that, I think at the end of the day, it is a substance too, right? And a substance that actually can, at the end of the day, also be misused and lead to other complications as well. So it shouldn't be the first line that is reached, but by all means, it shouldn't be not looked at either, right? So I think there's the double-edged sword that needs to be considered.
It's do your homework time, isn't it?
Yeah.
Seriously.
Oh,
Patricia.
Patricia's got,
Yep.
Let's hear.
Yep.
Yeah.
So personally, I have seen clients have great success with CBD and THC in helping relieve some of their arthritis pain. That was most of the patients we had at the clinic. Now, it is very individualized, and there are contraindications with cannabis and other medications. So it is important that you do have a healthcare professional to look over your prescription history to make sure there's no contraindications and that it can be beneficial for you. But I would definitely advise anyone who's experiencing arthritis pain to be looking into that.
Sure. Another question is, could THC/nabilone help with paranoia and negativity? Anybody want to take that one on?
I'm not sure. The THC part, I would probably be a bit concerned about, because it can have the opposite effect and kind of drive some of those distortions and things like that. But nabilone, and so nabilone is kind of a THC derivative. So I would be, and the people, and I'm just thinking too that the trial in dementia excluded people who had active delusions and hallucinations. So you know what, I would be very, very cautious there. Yeah. So I never say never. I think, we have to have a dialogue about it, but I would probably be pretty cautious.
Yeah, I tend to agree. Here's another question. Could pain be in the mind more than actually physical? Julie, you worked with CMHC forever. Would you like to speak to that?
Yeah, certainly pain is such a very personal thing. And for us to make a judgment that it's in someone's mind more than it actually is a physical experience for them is a pretty big leap. So I think it's all about, again, doing the thorough assessment, getting a good sense of, first of all, why is someone thinking it might be in their head? And what is the pain history for that individual? When did things originate? What caused what particular pains? How are they demonstrating it? If it's through the lens of their cognitive changes, or if it's through an older adult who doesn't have those cognitive changes. In either case, it's really doing that deep dive to understand that assessment piece and the origin of their pain before you make that conclusion if it's in their head or not. And I suspect if it's real to that person, it's real to them.
Yeah, pain is whatever somebody says pain is, right?
Yeah.
All right, thank you for that. And I think, Julie, this one's going to come to you because I'm pretty sure this is in the bottom right-hand corner of your infographic, if I'm remembering correctly. Is there a list of cannabis clinics associated with physicians that can be found online?
I'm going to actually defer that one to Patricia and see if she knows the answer to that. And that will not be on our resource list, actually, the ones that are specifically with prescriber attached to them. But go ahead, Patricia, if I could tap on your shoulder for that.
For sure. So there are a couple of local cannabis clinics that do work directly with physicians. Some of them have specialists such as nephrologists. So I would advise checking out our local ones, just doing a quick Google search, and you can always just make sure that they do have a physician on staff that is doing the prescription.
So literally, what would you type into Google? What would be your first choice?
I would type in cannabis clinic with doctor.
Thank you. Now, here's something that has come into the chat. Oh, yeah, go ahead, Julie. Sorry.
So, Patricia, from your knowledge, is there ones within the Waterloo-Wellington region that are actively working with physicians?
Yes. So the CCC, the Canadian Cannabis Clinics, they work with physicians. The Clinic Network, they actually work with a nephrologist. So I would highly advise them. And then there is,
and just so we let everyone know, a nephrologist is a kidney specialist.
Oh, okay. Yes, sorry.
Yep, that's okay. Yeah.
And then there's also Care Cannabis Clinics, which they work with a nurse practitioner that does the prescriptions.
Beautiful. Thank you.
Yeah. So I work with patients and families as a care coordinator. I've had patients and substitute decision makers share that they asked their family doctor about cannabis for management of agitation/anxiety, and their physicians have been telling them to just go to the local shop on the corner. Dr. Didyk, what is the CPSO direction for family physicians on best practice for supporting patients with responsive behaviors in relation to cannabis? Can patients and substitute decision makers self-refer to cannabis clinics that have the NP/ the doctor and the nephrologist support? That was a question that I think is probably common to many people. I have known of people who have gone to the doctor and the doc has not been very specific with them. So do you have a response there, Nicole? Something that you can share?
I'm Googling it right now because you know what? I mean, it says here that I think it's pretty much like we're prescribing any other medication, you know, like we have to document why we're using it, if it's appropriate in that patient. We have to think about the different routes of delivery, the potential side effects for that particular patient. So, you know, we can, and then get consent for treatment. And, you know, that's really I'm just, like I say, I'm just kind of Googling it and I'm looking on the college website, which I think anyone could look at. If you type in CPSO and cannabis, they've got this policy on cannabis for medical purposes. It's much like we would with any other medication. You know, like when we prescribe prednisone, we have to say, okay, well, you know, these are the potential side effects of prednisone. This is how you can take prednisone. So, but you know what, I can understand. I know when cannabis first came out, I was sort of like, oh, I gotta know all about this, you know, and it is intimidating. But the clinics are great. They're a wonderful resource if a person isn't comfortable prescribing themselves. And you know, I think advocacy, so much advocacy needs to be done, right, around so many interventions and so many things that we want to talk to our health providers about. So I think persistence, I think, you know, maybe bringing in the infographic or something like that, right? And say, hey, like, it seems like they're really trying to reach older adults around cannabis. Like, you know, it's really out there. Have you seen this?
And Nicole,
get
the
creative.
second part of that question was about self-referral to the cannabis
Oh,
clinic.
yeah.
So I wonder if Patricia can speak to that.
I definitely can. So you can self-refer to most cannabis clinics. The one that I worked for, we did require a full prescription history prior to any sort of prescription, just to ensure that there are no contraindications. There won't be issues with the medications that you're taking. But you can definitely self-refer, and generally they have a privacy policy that if you choose to consent to provide information to your family physician, they'll do so, but it is not generally required.
Thank you. Thanks, Patricia. Somebody is working with a resident who started CBD oil because she had a diagnosis of anxiety, but she's getting more anxious, and they're wondering if the CBD oil could be contributing to that and maybe should be discontinued.
So CBD can cause anxiety in some patients. So what I usually advise is the go low and slow method. So I would reduce the amount of CBD that you're taking until you find it's beneficial without any bad side effects. But again, it might be the type of CBD that they're taking. It could be an indica instead of a sativa. There's many different pieces to the puzzle on that one.
Yeah, it's complex, isn't it? Nothing in life is simple. And boy, cannabis certainly isn't.
It's just like we say with dementia. When you met one person with dementia, you've met one person. When you take cannabis, you're one person. Everyone's individualized.
Yeah, yeah. Very good point. Thank you. Thank you. I thought this was pretty interesting. Do those cannabis clinics work with long-term care facilities? So cannabis clinics with doctors. I'm wondering if that means that the docs would go into a long-term care facility, or would the person living in long-term care need to go out to the clinic? Have you ever heard of one of the clinics working with a long-term care facility?
From my experience, it was a direct patient. The physician generally didn't go into the long-term care. They would just provide tele support over the phone. But I don't see why it wouldn't be a great opportunity.
And then somebody has been sharing, you know, that they use cannabis and what they're on. And it's nice to know that this information can be beneficial to people who have maybe never even thought of trying cannabis, people who have been wondering about trying cannabis, people who actually are using cannabis. I think today's information will actually be good for a very wide audience of people. So I'm going to put out last call for questions here because we're running down to, yes, Nicole.
I got a direct message. I've gotten a few direct questions. One is, can you take Nabilone and drive? I don't think you have to stop driving when you're on Nabilone, but I think it's like any medication that can affect the brain. It's probably important to, as Patricia said, start low and go slow, and maybe let somebody else behind the wheel when you're just starting it and seeing how your body reacts to it. So by itself, it's not a drug that you cannot drive with.
Good to know. And did you have another question there?
Well, one of them was a health care provider who works with long-term care transitions, telling me that they find it's difficult to get the CBD and the cannabis compounds to to get them adopted by the teams in long-term care. And, maybe the physicians are a little bit late adopting there. So, I think we should organize this talk to the long-term care physicians and have a dialogue and see what the barriers are and, whether we could help if that's something families want. We could always start with education, right? But it is difficult. Change is hard and new things are new and scary.
Yeah, definitely. So everybody, if you just check your own private chat boxes, just make sure nothing else has popped in. That would be great. I do need to start to wind us down, but I don't want to miss anything that was put into the chat. So, okay. Oh, and they keep coming. All right. Well, thank you very much to our panelists today. I sincerely appreciate you sharing your expertise and your time. And I think that whether cannabis is something that you want to take on board or not, you can take on board that the Alzheimer's Society is here for any type of dementia at any point in the journey. That is pre-diagnosis, at diagnosis, during the journey, when you're thinking about long-term care, after admission. Please don't hesitate to reach out for our services. You need no referral for our services. Our services are available to anybody for the asking. It takes a phone call, that's all. You could reach us by email, but I suggest you call and then we can direct you to the right person and the right sort of help that you might need.
And the services are free. So
And the
that's always
services
good
are
to know.
free. Gotta love that. Yep, core services are free. So please watch your emails because we will send the evaluation and we will send the materials from today. If you haven't received it by tomorrow morning, check your junk mail. Every once in a while, things just go to junk mail. They go astray. It's a bit of a pain, but I would encourage you before you write me and say, hey, I got nothing, to think about checking your junk mail first. All right, I'm just looking, a few more things came in, but they were just very nice comments. So thank you very much to everybody who wrote something generous to us. And thank you, everybody. I hope that you enjoy the sunshine this afternoon. I encourage you all to stay safe and join us for another education another time. All right, this is goodbye. Thanks a lot.